Hello, and welcome. We're jumping right into a really critical topic today, the 2025 update on managing diabetic kidney disease. Honestly, the way we approach protecting our patients' kidneys has fundamentally shifted. There's a new four-pillar approach, and it's something we all need to have down cold.
So let's start with this number, because it really sets the stage. Up to 40% of our patients with diabetes will at some point develop chronic kidney disease. And you know, this isn't just about the kidneys, is it? It dramatically cranks up cardiovascular risk, which makes getting this management right an absolute top priority in our clinics.
For years, for decades, the absolute cornerstone of treatment has been RAS blockade, right? But the big story, the headline for 2025, is that RAS blockade alone is just not enough anymore. We've really entered a new era where a multi-pillar approach is the standard of care for our high-risk patients, and it's giving us a real shot at changing the whole trajectory of this disease.
Okay, so where do we begin? Well, it all starts with knowing exactly who's at risk, and, just as importantly, how high that risk is. This first step, screening and stratification, is what dictates our entire game plan.
The 2025 guidelines really just confirm what we've been doing. We're screening all of our type 2 patients right at diagnosis and our type 1 patients once they hit that 5-year mark. And of course, this means checking both the spot urine albumin to creatinine ratio, the UACR, and the eGFR every single year. These two markers together, that's what gives us the full picture of what's happening.
We take that data and plug it right into the KDIGO heat map. This thing is really our central tool for stratification. By plotting eGFR against albuminuria, we can classify our patients from low to very high risk. And it's so much more than a diagnostic chart, right? It's a direct guide to action. It tells us how often to monitor, from once a year in the green zones, all the way up to 4 or more times a year for our patients in the red.
Now, before we get into all the new and exciting therapies, let's just ground ourselves in the basics. These are the non-negotiables, the foundation that everything else is built on. We have to get these right for every single patient.
So the three foundational pillars haven't gone anywhere. They're still absolutely essential. Number 1, aggressive blood pressure control, aiming for under 130/80. Number 2, solid glycemic control with an individualized A1C target somewhere around 7.0%. And number 3, of course, for any patient with albuminuria, we're starting a RAS blockade with an ACE inhibitor or an ARB, and we're pushing that dose to the maximum tolerated.
And on that note, here is a hugely important point of practice. The data on this is crystal clear. Do not use dual RAS blockade. We know from landmark trials like VA Nephron-D that combining an ACE and an ARB gives you zero additional kidney protection, and in fact, significantly increases the risk of bad outcomes, specifically acute kidney injury and hyperkalemia. So, one or the other, never both.
All right, let's get to the core of this update. This is where the practice is really changing. We're moving beyond those foundational elements to the 3 additional classes of medications that are completely revolutionizing how we manage DKD. This is the new 4-pillar approach.
Our first new pillar, the SGLT2 inhibitors. You know, thanks to trials like Credence and DAPA-CKD, we know these drugs deliver a powerful 1-2 punch. They robustly slow down CKD progression, and they have a massive impact on reducing heart failure hospitalizations. The 2025 guidelines are now recommending their use in patients with an eGFR all the way down to 20.
The second new pillar is the GLP-1 receptor agonists. The FLOW trial was a total game changer here, really cementing their role. These agents are a fantastic choice for our patients who also have atherosclerotic cardiovascular disease or obesity because they offer proven MACE reduction and weight loss on top of slowing CKD progression.
And our third new pillar is the nonsteroidal MRA, finerenone. The data from the Fidelio and Figaro trials showed us just how effective it is at reducing both CKD progression and cardiovascular events. It's a great option for a really broad group of patients who have that persistent albuminuria and an eGFR of 25 or higher.
So we have our RAS blockade as the foundation, and now we've got 3 powerful new tools in the toolbox. This leads to the obvious clinical question, right? Which one do we pick first? Thankfully, the answer isn't just a coin toss. The modern approach is really a form of precision medicine. We let the patient's clinical profile, their specific comorbidities, guide our decision. This lets us choose the agent that's going to give that individual patient the biggest bang for their buck right from the get-go.
And the algorithm is actually pretty straightforward. If your patient has heart failure, any ejection fraction, the SGLT2 inhibitor is the clear first choice, no question. For a patient with known ASCVD but no heart failure, you're choosing between an SGLT2 inhibitor or a GLP-1RA. And if the main problem is just persistent albuminuria without those other major comorbidities, well, then any of the three new classes is a perfectly reasonable place to start.
Okay, so let's talk about what happens next. Starting that first agent is just the beginning. For our higher-risk patients, the goal is comprehensive protection, and that often means layering therapies and, of course, monitoring them very closely. So, if you've started your first new agent and the patient's albuminuria is still up, say a UACR of 30 or more, you don't just stop there. The evidence is strong that we should be sequentially adding agents from the other protective classes to really stack those benefits and get maximal cardiorenal protection. Now, this is a really critical point for day-to-day practice. When we start an ACE inhibitor, an ARB, or an SGLT2 inhibitor, we have to know how to interpret the labs that follow. You are going to see a bump in creatinine. A rise of up to 30% that then stabilizes is not only expected, it's actually a good sign. It means the drug is working, it's reducing that intraglomerular pressure. It is not AKI. Now, a rise over 30% or one that just keeps climbing, that's your red flag. That's when you hold the agent and start investigating.
While all these new therapies empower us to do so much more for our patients, it's also absolutely crucial to know our limits and to know when it's time to get our nephrology colleagues on board.
The indications for referral are really clear-cut. Any patient whose eGFR drops below 30, that's a definite referral. Anyone whose numbers are getting worse fast despite your therapy, that's another one. If you have any uncertainty about the diagnosis, or if you're struggling to manage complications like resistant hypertension or hyperkalemia, it's time to make the call.
Okay, let's wrap this up and bring it all together. What is the new standard of care for diabetic kidney disease in 2025?
This is it. This is the new paradigm. For our high-risk patients, comprehensive management is now built on 4 pillars. We start with that foundation of RAS blockade. Then, guided by comorbidities, we sequentially layer on an SGLT2 inhibitor, a GLP-1 receptor agonist, and a nonsteroidal MRA to truly maximize protection.
This whole shift really leaves us with a provocative thought. For the first time, we have a toolkit with multiple, proven therapies that we can stack to provide just incredible cardiorenal protection. So the question for all of us is, can we implement this new standard so effectively that severe DKD progression becomes a rarity, the exception rather than the rule, in our patients? I think the potential is definitely there.